Hi everybody, this is Professor Schumann, and I'm going to be talking to you this afternoon about acute brain attack, or better known by most people as cerebrovascular accident or stroke. Now the reason that we have really prefer the term acute brain attack is because we really want to get across to the public that a stroke is really an emergency, and if people will get to the hospital and get in for treatment early when the symptoms of a stroke appear, there are some treatments that can be used to actually stop some of the damage that can occur from a stroke. And we'll talk about that as we go through this lecture, but we need to impress upon the public that when people have symptoms of a stroke, they shouldn't just sit at home and wait to see how things go, which is what most people do. Oh, I'll just, see how it goes, and if this weakness in my arm, isn't better tomorrow, I'll go check it out with my doctor. Well, that isn't really the correct thing to do. So we've started to use the term acute brain attack more frequently in trying to get the public to realize that when someone has signs or symptoms of a stroke, they need to get to the hospital very quickly, so that we can treat them very quickly and hopefully arrest what's going on and preserve as much brain function as possible. So we have some learning outcomes in the lecture today, and what these learning outcomes are is that at the end of the lecture you'll be able to describe the pathophysiologic processes for the two major types of CVAs. You'll be able to describe the early clinical manifestations that are universal to stroke victims. You'll be able to differentiate between the clinical manifestations of a right-sided stroke versus a left-sided CVA. You'll be able to identify the type of stroke that TPA, tissue plasminogen activator, can be used to treat, and discuss the precautions to be used with this drug. And lastly, be able to explain why early diagnosis of CVA is so crucial to treatment, and you'll be able to formulate a care plan to be used for a patient during the acute phase of a CVA, utilizing appropriate nursing diagnoses and interventions. Let's first define what we mean by cerebrovascular accident, CVA, or stroke, or what we're going to try to commonly call now a brain attack. What we're talking about here is a sudden loss of brain function resulting from the disruption of blood supply to the brain. And this loss of function can be temporary or it can be permanent. It depends on how long the blood supply is cut off to the particular part of the brain that we're talking about. Stroke is the third leading cause of death in this country, so it has a very high mortality rate. And even though mortality for people who are having their first stroke is, it looks like it's not really that high, only 18 to 37%, people who have their second stroke or subsequent strokes, 62% of them will die. So it's not the first stroke that is the killer so much, but it is the subsequent strokes, and those are very common. Once somebody's had one stroke, it's very common they go on to have another stroke. And not only death from strokes, but just the disability that occurs with a stroke is very far-reaching. 25 to 40% of stroke survivors will need some kind of assistance with their activities of daily living. So if someone is fortunate enough to survive a stroke, almost half of them will have some sort of permanent disability which they will need help with. So the consequences of a stroke, can really be very far-reaching and very long-lasting, not only for the patient themselves, but for the family and really for the whole community. If that person was the breadwinner for the family, they may not be able to go back to work. If they were the caregiver at home for someone, they may not be able to do that anymore. So very often the consequences of somebody having, a stroke are very very profound, and we need to be aware of that and really try to help them regain as much function as possible. The American Heart Association estimates that there are 780,000 strokes per year, and that of these 780,000, 600,000 of them are new strokes, and about 180,000 are recurrent strokes. Now, I've been finding some conflicting information, this next bullet point on the slide. Your book actually says, I think, men have more strokes than women, but your book also says that women die more often than men of strokes. So, I would go by what your book says, because it's more current probably than the slide, because I've had this lecture for a few years. American Indians and Alaskans have the highest prevalence of strokes, and African Americans, you're probably aware, have a very high incidence of strokes as well, twice as many as Caucasians. So the minority groups do have a very high incidence, and the Hispanics, are in those minorities that also have a higher prevalence than Caucasians. Now, strokes can broadly be classified into ischemic strokes or hemorrhagic strokes. The majority of strokes, 87%, are ischemic. And we'll explain what we mean by that in just a minute. And a much, much smaller percentage are hemorrhagic. And of the hemorrhagic strokes, 10% are intracranial, meaning in the brain tissue itself, and only 3% are subarachnoid, meaning between the skull itself and the arachnoid membrane, which is covers the brain. Now, ischemic strokes, the majority of strokes, result from an occlusion of a blood vessel. As you remember from anatomy and physiology, the brain must receive a steady supply of oxygen and nutrients to function. And the brain is one of the most sensitive areas of the body, if not the most sensitive area, to hypoxia and to hypoglycemia. The brain is, one of the areas that needs that constant supply, and it doesn't adapt very well when it is deprived of oxygen or glucose. So the brain, is really dependent on having a constant supply of these nutrients, and it does not like to be deprived. So if a blood vessel becomes occluded, that cuts off the brain's supply of oxygen and glucose, and very quickly that brain tissue that's being supplied by that blood vessel is going to lose oxygen and glucose, and it is not going to be a happy brain tissue. If you recall, there's two major pairs of blood vessels that supply the brain. The internal carotids, which of course, go up your neck, where they are in the front of your neck, and then the vertebral arteries, which combine more, further back in your neck here and kind of combine at the base of your skull to form the basilar artery, which then goes up and feeds more of the back of the brain. And so then those two sets of arteries sort of branch off and develop into all the other arteries that do feed the brain. There's 4 types of ischemic strokes. We divide them into thrombotic, embolic, idiopathic, and other. Now, thrombotic strokes are the most common cause of strokes, and these are usually resulting from an accumulation of atherosclerotic plaque in the vessel lumen. And plaque, as we talked about, or as I wasn't there, I think Professor Clapp might have taught you about coronary artery disease. the atherosclerotic plaque that builds up in the blood vessels. This takes, years for this to happen, and the plaque builds up very gradually. So when a stroke is caused by a thrombus, patients will oftentimes, as that plaque is building up over time, they'll often have sort of a little warning that something is going on in one of their blood vessels in their brain. They'll have a transient loss of function, and we call that a TIA, a transient ischemic attack. And, you've all heard of a mini stroke. That's what we're talking about here. They'll have some temporary loss of function, and what that's caused by is that blood vessel where the plaque is building up, the blood vessel is almost completely occluded, and so they almost lose all circulation to that part of the brain. But then something happens and the blood sort of pushes its way through, and it makes it through, and the symptoms go away for a time, and the patient probably thinks, oh, everything's fine, the symptoms went away, so I'm not going to worry about it. Well, unfortunately, if they ignore the symptoms, they're doing themselves a great disservice, because that is really, they're very lucky if they get that warning sign of a TIA, because that's just telling them that something's going on, and if they don't act quickly, pretty soon they're going to have a complete occlusion. And this is just a picture of, kind of for you to think about what it looks like inside the blood vessel. Here you have the plaque that's building up over years and years, of a poor diet, perhaps smoking is going on, lack of exercise. The plaque is building up. And what actually causes the stroke, and this is exactly the same process that occurs with coronary artery disease and somebody having an MI, for some reason this plaque gets injured. It oftentimes happens where the vein, or the artery, bifurcates or divides, and the blood flow is extremely turbulent here where the blood vessel is dividing, and some of this plaque breaks off, and the body senses that as an injury. And so what does it do when it thinks there's an injury? It sends the repair team. And so the repair team, consists of platelets and all the clotting factors, and they all come on the site to fix the injury, not realizing that the injury, in this case, is injury to the plaque, which we could really do without. So they come to try to fix the injury to the plaque, and all these platelets and clotting factors form a nice clot, and the next thing they've done is totally occlude the blood vessel. Now, they didn't mean to do that. They meant to just stop the bleeding from this intimal injury here. But what they've done, in effect, is stop the blood flow from going any further down this blood vessel. Now, the kind of stroke that is an ischemic stroke is called an embolic stroke. And you all know what an embolus is, if you remember from anatomy. An embolus is simply a clot that goes from one place to another, so it transfers itself, travels somewhere. So you'll notice in this case, we don't have that plaque, because an embolus is simply a clot that goes from one place, travels through the blood vessel, and then gets lodged somewhere else. So in this case, this clot could have been in the heart, it could have been somewhere in the lower circulation, and it ended up traveling to the brain and got stuck because this blood vessel happened to be smaller than the blood vessel that this embolus came from. Now, one of the biggest sources of embolic strokes is patients who have what we talk about as an arrhythmia called atrial fibrillation. And what happens with atrial fibrillation is the blood is sitting in the heart, and instead of the heart pumping nice and smooth with every heartbeat, it just fibrillates or quivers. And when it quivers like that, the blood sort of gets a little bit more coagulable, meaning it gets sort of where it's not as smooth and free-flowing. It gets thicker and more viscous, and clots form more easily. And if you think about the location of the heart and the location of the brain, and the ascending aorta that comes right off of the heart, if any of those little clots that form in the heart were to break off of the heart, come out of the heart and travel out of the ascending aorta, where's the easiest place for them to go? Well, they shoot right up the carotid arteries and shoot up into the brain. So this is where the source of a lot of embolic strokes comes from, is from atrial fibrillation. And that's why we don't really like people to be in atrial fibrillation, because the resulting strokes that occur with somebody who has atrial fibrillation is pretty common. Now, embolic strokes tend to not have that warning sign of a TIA, because that clot, when it travels, it usually causes symptoms that occur quickly and they don't go away. So you have usually a sudden onset of hemiparesis or hemiplegia, with or without aphasia. Aphasia, remember, is difficulty with speech, or the patient may even pass out. And it's usually in a patient who has cardiac or pulmonary disease. And as I said, the most common cause of emboli are atrial fibrillation. Now, the other two big classifications of stroke, embolic and thrombotic, are idiopathic strokes, of which 30% come under this classification. And these are the strokes for which no cause can really be identified. And then the other classification, which is about 15% of strokes. And these are causes such as vasospasm, inflammation, coagulation disorders, and the effects of drug abuse. Now, hemorrhagic strokes, which again, remember, that's the other big category, opposite thrombotic strokes. And hemorrhagic is just a very small percentage of the big classification of strokes. Hemorrhagic strokes are caused by the sudden rupture of a vessel in the brain. And what happens is the blood then leaks out of the blood vessel and the blood permeates the brain tissue. The blood is very noxious to that brain tissue. And also, besides it being noxious and really toxic to the brain tissue, a hematoma forms. And basically then you have happening what happened with the ischemic stroke as well. You have compression of the brain tissue and increasing ischemia, and the final result is the same as the thrombotic stroke. You have lack of oxygen and lack of nutrients getting to the brain tissue, and then you have death of the cells. Now, there's 4 locations where these hemorrhages can be formed, and you have to think about the layers. If you were starting on the outside, of the skull and working your way in towards the center of the brain, that's how we're thinking of these locations. So the epidural hemorrhage is between the skull and the outermost membrane that covers the brain, the epidural membrane. So right in between, here's the skull, and here's the membrane that covers the brain, the outermost layer of the brain. So here's where an epidural hemorrhage is. The next layer in would be a subdural hematoma, and that is below the dura, which would be under here. It's actually pictured here, and that's between the dura mater and the arachnoid mater. So here is where you would have a subdural hematoma. Now, these two types of hemorrhage are usually caused by some sort of trauma, whether it's a car accident or a fall. All of those things are considered to be head injuries, and they'll be discussed more in depth when you get into complex adult health. The other two types of hemorrhages are a subarachnoid hemorrhage, which would be between the arachnoid membrane and the pia mater, which is the covering that is right on top of the brain itself. And then intracerebral bleeds are within the brain tissue itself. And we talked a little bit about them earlier, saying that the bleeding is right into the brain tissue and it's very noxious to the brain tissue. So any one of these bleeds can be very fatal to a patient, depending on the location and the size of the bleeding. For a subarachnoid hemorrhage, the most common cause is a leaking aneurysm in the area of the circle of Willis. And I'll show you a picture of that famous circle of Willis in just a minute. But an aneurysm, if you don't remember that from anatomy and physiology, is an outpouching of a blood vessel. And so that place where the blood vessel wall is outpouched is weaker than the rest of the blood vessel because it's, stretched. So it's not as strong as the rest of the blood vessel. And so it's more prone to bust open when you have turbulent blood flow or high blood pressure or any of a number of factors. The peak incidence of aneurysm rupture for most patients is between 40 and 65 years old. And the mortality rate is usually about 40% for the initial insult. These, unfortunately, do not give you a lot of warning, and once an aneurysm ruptures, you don't have much time to get them to the OR and repair that aneurysm. So it's very difficult to save these patients. There's several different types of aneurysms, and they have different names. It's not really that important, but I just thought it would be interesting for you to see what some different types of aneurysms look like. The one on the far left is right at the bifurcation of a blood vessel there. And that one is called a saccular aneurysm. The next one over, this one right here, this is called a berry aneurysm because it kind of looks like a berry. And then this one is called a fusiform aneurysm. And this one is called a dissecting aneurysm. And these are particularly troublesome because they're kind of just tearing down the horizontal length of someone's blood vessel. And once they start tearing, they can tear the whole length of the blood vessel, and you can lose an incredible amounts of blood very quickly. An intracerebral hemorrhage, this is the one where the blood is leaking right into the brain tissue itself. These can occur in a patient of any age, but in patients who are 40 to 70 years old, they're usually caused by degenerative changes in the patient's blood vessels, either due to hypertension or cerebral atherosclerosis. If they occur in patients less than 40, they're usually caused by an arteriovenous malformation, which is something the person is born with and just isn't aware that they have it until early adulthood. They can also be caused by tumors or by trauma. And typically an intracerebral hemorrhage will present with the patient having a pretty quick onset of a very severe headache and then rapid neurologic deterioration. Now this risk factor list should look very, very similar to another risk factor. These risk factors should be very familiar to you from your discussion about coronary artery disease. And we also discussed peripheral vascular disease. If you haven't listened to that lecture yet, you'll notice that when you do listen to it, the risk factors are very similar to this list as well. And the reason is because it's really the same disease, whether we're talking about the blood vessels in the brain or the blood vessels in the heart or the blood vessels, in the peripheral limbs. The blood vessels are the blood vessels, and the risk factors affect them regardless of what location they're in the body. So if you have a patient with coronary artery disease, most likely they have some cerebrovascular disease as well. And if they haven't been diagnosed with it, it's just because they've been lucky enough not to have any symptoms yet. But you look at your patient's H&Ps, and how many of them, if they have CAD, do they also have a stroke? Or do they also have PVD listed in their H&P? Because, as I said, it's one and the same disease. It's just manifested in different parts of the body. So when we're, getting patients to try to stop smoking or control their hypertension or eat properly, we're not just doing it for one, spot in their body. We're really doing it because their blood vessels throughout their body don't do well when their blood pressure is high. Nicotine, negatively affects the blood vessels from the tip of your toes to all the blood vessels in your brain. It's not just, the ones in your coronary arteries. So you need to get to know these risk factors really well. You need to know what to teach patients about them. You need to know which ones are modifiable, which ones are non-modifiable. The non-modifiable ones obviously are the ones that patients can't do anything about, but having them makes them more at risk for CVA and for PVD and for coronary artery disease. And so if they have a lot of the non-modifiable risk factors, they should really work on the modifiable ones to reduce their overall risk factors. The non-modifiable ones, as you see here, age greater than 65, being male, African Americans and Hispanics are more at risk than Caucasians, having a family history with somebody else in the family having a history of having a CVA, puts the patient at more risk. The modifiable risk factors, and there's many, many things patients can do to reduce their risk. Hypertension, smoking, diabetes, oral contraceptives, obesity, high cholesterol, a sedentary lifestyle, knowing that you have atherosclerosis, and atrial fibrillation all contribute to the development of cerebrovascular accidents. So the clinical manifestations of CVAs really can be any neurodeficit, and it really just depends on where the occlusion of a blood vessel in the brain is, how long the ischemia has gone on, and how much collateral circulation you have in that region. This will determine what kind of manifestations you'll have with your stroke. Now, a stroke that is caused by a thrombus during sleep or during rest is the way about 60% of strokes will present themselves. And that's unfortunate because if somebody has gone to bed in completely perfect condition and wakes up and they have symptoms of a stroke, we have to assume that the stroke happened shortly after they went to bed because we don't know. And it's going to be very difficult for them to be a candidate for TPA because we have to catch their symptoms, so to speak, early on. And if they've been in bed for 8 hours, they're not going to be a candidate for TPA because we have to catch them much earlier than 8 hours if we want that TPA to be effective. So unfortunately, when patients have gone to bed and been normal and gotten up in the morning and not been normal anymore, it's very difficult to offer them much treatment. So as I said before, the symptoms of a thrombotic CVA can develop abruptly, or they can sort of progress over a period of hours, usually, over 2 to 3 days. Whereas embolic and hemorrhagic strokes are much more likely to develop very suddenly and progress rapidly. You don't usually have much warning with an embolic or hemorrhagic stroke. There's a couple of terms that you'll hear when you're talking about strokes that I thought I would define for you. There's sort of a couple of them are more old-fashioned terms that they don't tend to use a whole lot, but you might hear them tossed about, so I thought that I would just define them for you. A stroke in evolution simply means a stroke that has not completely, the occlusion has not, well, I put it this way, the damage is not completely done. So the damage is continuing, so that you cannot determine exactly what the final damage will be. A completed stroke, on the other hand, they feel that the damage is finished and they can predict what the person's deficits will be. And a transient ischemic attack, I already talked about that. And that's when there's partial occlusion or temporary occlusion of a blood vessel and the person has temporary symptoms that go away. And usually a transient ischemic attack, the symptoms go away within 24 hours. The specific clinical manifestations of a stroke can be divided pretty much into these 5 categories, and we'll go into them a little bit more specifically, but motor deficits, communication deficits, sensory perceptual deficits, cognitive emotional deficits, and bowel and bladder deficits. And as I said, we'll go into these a little more in depth. Deficit is usually the most commonly presenting symptom of a stroke, and it can be anything. It tends to be on one side of the body only, because most strokes tend to occlude a blood vessel on one side of the body. You can have global, which means both sides of the body, but that's a very, very large stroke if that happens. So you're going to usually have some sort of disturbance of motor control on one side of the body. And remember that the motor neurons do cross over to the opposite side of the brain. So if someone has damage on the right side of their brain, it's going to be manifested by having damage on the left side or deficit on the left side of their body. Remember that the most common motor dysfunction is hemiplegia, which means paralysis. They could also have hemiparesis, which is a weakness on one side of the body. It's important that you distinguish those two terms, because paralysis doesn't tend to get any better, but paresis or weakness, there's more that they can do as far as rehab with the patient and getting them to use that limb again. Other motor deficits that the patient may have could be ataxia, which is difficulty with their gait when they're walking, dysarthria, which is difficulty in the movement of the mouth for speech. So it's not aphasia, that's different. Aphasia has to do with the thinking part of speech, but dysarthria is difficulty moving your mouth correctly to make speech. And dysphagia, of course, is difficulty swallowing. Communication deficits are very commonly occurring with strokes, and I don't think we always think about the fact that speaking is a very complicated process, and basically it can be broken down into receiving and understanding speech that is spoken to us, and then the other side of the coin is us speaking to someone else and getting our point across. For most people who are right-handed, the left hemisphere of the brain is going to be the dominant side of the brain for speech. And it's also going to be dominant for some left-handed people. So people who have a left-sided stroke are going to be the ones who are affected more. Their speech is going to be more affected than those who have a right-sided stroke. There's 2 different parts of the brain that are involved in speech. And one of them, again, has to do with the understanding of speech that is spoken to us, and one of them has to do with the speech that we ourselves, form. And you probably learned this back in A&P, but it'll make more sense now, I think. The part of the brain that is concerned with making speech, us speaking to other people, is called Broca's area, and that's found in the frontal lobe, right here, this yellow area. So that's the motor area of speech, Broca's area. And then the part of the brain that is concerned more with understanding speech, processing speech, is called Wernicke's area. And that is right back here in the temporal lobe. And I kind of remember Wernicke's area because I kind of superimpose, a face and a head on here. And this is where your ear would be. So your hearing and your processing of, your understanding of speech, they're very close to one another. So that's just my little remembrance tip for that particular area. So people who have difficulty understanding speech, we call that receptive aphasia because they can't understand or process speech. Those who have difficulty expressing themselves, getting the speech out, that is called expressive aphasia. And if they have problems with both expressing themselves and understanding what is being spoken to them, that is called global aphasia. Another area of deficits for someone who's had a stroke are sensory perceptual deficits. And these can be divided up into sensory, visual, and perceptual deficits. And this is something that you need to sort of be more aware of because it's not so obvious as someone who can't walk or someone who can't speak. So you need to really be aware and, looking out for these types of deficits. Perception, of course, is the ability to interpret sensation. And it's also a very complex process of recognizing and then interpreting stimuli that we take in from the environment. And for perception, the right side of the brain, especially the parietal lobe, is very important. So again, my little memory tip is parietal and perception to help you remember that one. Sensory deficits can range from a slight impairment to very severe. And again, you need to be very aware and astute about this with your patient because their sensory deficits aren't going to jump right out at you all the time. So you need to be aware of them because they may not be real obvious. But sensory deficits can range from something very slight to something, very severe. And one of the things that they can have wrong is agnosia, which is the inability to identify familiar objects by use of their senses. So I always think of that scene in The Little Mermaid where she goes into that treasure cave and she has all these treasures she's discovered under the sea, but she has no idea really what they're for. She just calls them her treasures, and she pulls out like a fork and she combs her hair with it because she has no idea what it's really supposed to be for. And so that would be visual agnosia because she's unable to, with her eyes, identify what that object is for. Auditory agnosia is by hearing something, the sound of something, knowing what it's for. So like, hearing a church bell and knowing that it was chiming the time of the day. And tactile agnosia would be, to be able to feel something in your hand, like identify an ice cube in your hand and know that that was, something to keep a drink cold. So this decreased sensation of touch, heat, and cold certainly places the patient at risk for injury. They might forget that the stove is hot when it looks bright red and just, put their hand right on the burner. So you have to really watch them carefully because they may not be able to protect themselves. Visual deficits are also very confusing that they may have and also not very obvious. They can have a disturbance of the primary sensory pathway between the eye and the visual cortex, which is in the occipital lobe. And the affected side of vision corresponds to the paralyzed side of the body. So if they have right-sided weakness, they're going to have, if they have any visual problems, it's going to be on that same side of the body. They could have just decreased visual acuity. They could have double vision. But it's very common for them to lose the visual field in both eyes, part of the visual field. And this is called homonymous hemianopia. So here they've lost the right visual field in both eyes. So again, very dangerous because they can't see what's in that right visual field. There could be a stoplight there that they're not seeing, or, an approaching car or something. Perceptual deficits can also be very dangerous for the patient because they can be at risk for, injury. Loss of proprioception. Proprioception is the ability to identify where you're at in relationship to your environment. So, you could end up being standing next to something very, very hot or something very cold. Unilateral neglect syndrome is when the patient is not aware that they have one side of their body or the other. So they totally lose sight of the fact that they have a right side of their body. And so they would just take a shower and wash the left side of their body, wash the left side of their hair, shave the left side of their face, put on clothes on the left side of their body. And you would have to remind them, make sure you put your right sleeve in your shirt, put your right shoe and sock on, or they would totally forget to do anything with that right side. Apraxia is losing or forgetting a number of steps that you need to do a particular task. Let me think of an example. Like maybe brush your teeth. You have to open up the tube of toothpaste, squirt the toothpaste on the toothbrush, put the toothbrush in your mouth, brush it around, spit out your toothpaste, rinse your mouth, brush a little more. They would totally forget those steps. And they also could lose the ability to judge spatial relationships. So this could be very dangerous when driving. They're unable to judge, the distance of an approaching car to know if they can turn or not. So very often they may lose their driver's license. Bowel and bladder deficits seem to be very common, but sometimes they're the easiest things to overcome. Frequency, urgency, and incontinence, urinary-wise, can occur in the early days of stroke. But bladder retraining is not all that difficult because usually the stroke lesion will only affect half of the bladder. And so when they go to rehab, their bladder can be retrained using the half of the bladder that is still functional. And so with special techniques and toileting them every so often, they can really regain that bladder control. And the bowel elimination that they oftentimes have is often related to cognitive losses and immobility rather than actual physical effects of the stroke. So they can usually be taught, to hold it till someone takes them to the bathroom every morning at 9 o'clock, or, they can be given a suppository or stool softener that sort of manages their bowel habits on a regular basis. Cognitive emotional deficits also can occur with strokes, and these are sometimes very difficult to deal with because they almost become childlike with their emotions. Their personalities will sometimes change very drastically, and it's kind of difficult for family members to accept what happens with people who have had strokes. They may lose control over their emotions. They may have exaggerated emotional responses. They may have flat or inappropriate affect, or they may become very unpredictable. Depression is very common as they realize the deficits they've endured and realize that a lot of it's not going to come back. Memory and judgment are commonly compromised. A lot of stroke patients will have short attention spans and easy distractibility. They'll have an altered ability to reason and to think abstractly. And some of these emotional and personality deficits will kind of manifest themselves in sometimes patients will have almost a really weird personality change. People who have right-sided brain damage, so that their paralyzed side is on the left, will exhibit this left-sided neglect and spatial perceptual deficits. And their personality will be such that they'll tend to deny or minimize their problems. They'll become very impulsive. They'll have a very short attention span. They tend to minimize their deficits and really just ignore them. And they put themselves at risk because they do this minimizing of their deficits. Whereas people who have a stroke on the left side of the brain and have left-sided brain damage, they have the opposite emotional response. They're very aware of their deficits. They become very depressed about it. They become very afraid to try anything. They're very cautious and withdrawn. They just, they kind of just go into their shell and are very, very hard to bring out of it. So it's really two different personalities altogether. And it can be very difficult for the family because you can have somebody who used to be very outgoing and friendly, and all of a sudden they just don't want to talk to anybody. So you have to talk to the family about the fact that it really has an organic base. It's not, that something happened that changed their personality, but it's as a result of the stroke, and hopefully, things will go back to normal. We've already talked pretty much about the way the ischemic stroke versus the embolic stroke presents itself, and how the ischemic stroke, may have warning signs with a TIA and kind of progresses a little bit slower, whereas the embolic stroke or the hemorrhagic stroke will be much quicker onset and not a lot of warning signs. It's really important, as I said, to diagnose a CVA quickly as to the cause, because if you can rule out a hemorrhagic etiology, in other words, that there's bleeding going on, then you can try to treat the patient with TPA, which is the clot buster medicine, and you can try to restore some circulation to some of these areas of ischemia. So the best and really the only way in a hurry to diagnose whether you have a hemorrhagic or an ischemic stroke going on is by a CAT scan. It's the gold standard. And most emergency rooms have a standard by which they measure their quality. When a patient comes in with stroke symptoms, they try to get them to the CAT scanner within like 20 to 30 minutes. And you'd be surprised, for as long as you have to wait in the emergency room, for most complaints, if you come in complaining of chest pain or stroke symptoms, you will get treated very, very quickly. They will get all of your labs drawn, and they will get you over to the CAT scan machine very, very quickly, because there really is a sense of urgency with the treatment. Now, a CAT scan will not really show the ischemia at the time that it's occurring, but what it will do is show bleeding immediately. So what happens is that when they do the CAT scan and they don't see bleeding, then they know they're safe to give the TPA, because if they don't show the bleeding, then they know there is no bleeding, and they can assume very safely that there probably is an ischemic cause for this CVA. So again, the treatment depends on what the etiology is, whether it's hemorrhagic or ischemic. And treatment sometimes can be surgical if it's technically and anatomically feasible. And the three goals of the initial management are going to be to maintain a stable cerebral perfusion pressure. And the cerebral perfusion pressure is a calculation that's done between your systolic blood pressure and your mean arterial blood pressure, but basically it involves keeping your systolic blood pressure around 150. So when we're dealing with patients who are having strokes, we don't want to take their blood pressure down too terribly low, because we are going to then decrease the perfusion to their brain, and that's not what they need while they're undergoing a stroke. Second goal that we have when we're treating a hemorrhagic CVA is to stop rebleeding. And so we're going to use something to stop the bleeding, and that's usually a drug called Amicar. And then the third thing we want to do is prevent vasospasm from occurring. And this is done by expanding the intravascular fluid volume and by giving a calcium channel blocker, nimodipine or Nimotop. And then sometimes they will use steroids to help prevent vasospasm as well. It's a common intervention, but it is somewhat controversial. So if the hemorrhagic stroke is due to an aneurysm rupture, they're going to try to get in there and clip the aneurysm or stop the aneurysm. And as we said earlier, the peak incidence of aneurysm ruptures is between ages 40 and 65. And these aneurysms usually occur in the circle of Willis, which here is a picture of us looking up at the brain from down below. And here's the circle of Willis, right here. So we have an aneurysm somewhere in there, and we're going to want to go in there and try to clip that aneurysm. Now, a hemorrhagic CVA that's due to an aneurysm rupture, the person's going to say, I have the worst headache of my life. And then they're going to lose consciousness very shortly after they make that statement, because their intracranial pressure goes up so high. And they're going to have focal or widespread symptoms of an acute stroke. Then if it starts to bleed, it doesn't matter, because we've cut it off from the blood vessel, and it can do all the bleeding it wants. It's not really going to hurt anything. Then on the right here is a procedure called a wrapping of an aneurysm, and they take, a surgical material and just wrap it around the blood vessel to kind of give it support so it won't burst. So the acute care management of a stroke, most facilities will use the NIH stroke scale to guide their interventions. And there's a sample of the NIH stroke scale in your textbook. You can take a look at it. But it's a very in-depth neurological assessment of a patient when they're having a stroke. And it just helps you kind of get an idea of how the patient's doing. You can monitor their progress, whether they're deteriorating or getting better, by looking at the numbers that go along with the NIH stroke scale. You can guide your therapy to see whether they're getting better or not. You're going to also monitor the patient's vital signs. You're going to monitor their respiratory system, particularly being very careful about how they're swallowing. You should never feed a stroke patient who you haven't tested for swallowing problems. And so most nurses, once you go to work in a hospital, they'll train you on how to give the patient just some sips of water first, and then just spoonfuls of water, and then something like peas or something very small to see if they can swallow adequately. They will also have speech therapy perform a swallowing study on every patient who's had a stroke. That's their specialty, to test whether the patient has got any swallowing dysfunction or not. And any patient who does have swallowing dysfunction will be followed by a speech therapist until they are able to, manage their secretions and manage food. The patient will probably be kept on bed rest until they're evaluated by PT and OT, and they will support their musculoskeletal function. You'll want to assess their elimination problems and work with them for that. You'll want to do a baseline neurological assessment and frequent ongoing focused assessments. Their blood pressure is commonly elevated immediately following a stroke. So you're going to want to monitor that pretty closely and get them into the high range of normal. You certainly don't want to take them if they've been running 180 over 90 for years. You don't want to drastically bring them down to 100 over 90 or 100 over 80, because most patients are just not going to tolerate that. So you want to bring them down, gradually, and make sure that they're tolerating a lower blood pressure. You're also going to want to monitor their fluid and electrolytes and make sure you're keeping them adequately hydrated to promote perfusion and decrease further brain injury. Now, patients who've had a hemorrhagic stroke, we are not going to want to give them any kind of anticoagulants or platelet inhibitors. They're already bleeding. They don't need any more encouragement by us giving them anything like that. You're going to want to try to manage their blood pressure. There's oral and IV agents that are used to maintain their blood pressure within a normal to high normal range. Seizure prophylaxis is very important, and most patients will be on some sort of medication if they've had a stroke to prevent seizures, because it's very common that they will get seizures. And vasospasms can be treated with the calcium channel blocker nimodipine or Nimotop. For an ischemic stroke, you kind of divide the treatment time into the immediate and then to the ongoing treatment. The immediate treatment for an ischemic stroke, you need to give them TPA if you're going to, at the latest within 4.5 hours of them having had the CVA. As I mentioned before, if the person wakes up and they've had the symptoms since they woke up and you don't know what time they went to sleep, you're going to have to assume that they had it as long as they were sleeping. So tissue plasminogen activator is what's called a recombinant tissue plasminogen activator that helps to reestablish blood flow through a blocked artery to prevent cell death. And when this first came out for heart attacks about 20 years ago, it was like the wonder drug, because it can actually blow through or lyse clots. And we thought it was the most wonderful drug we'd ever discovered. However, every drug has a silver lining. And the silver lining for this one is that just like it stops the clot and opens it up, anywhere else in your body where you had anything recent. Also, we don't recommend giving the patient anticoagulants initially because they're going to get a nice high dose of TPA, and that's going to make them pretty prone to bleeding. So they're not going to be needing any anticoagulants in the first, usually 24 to 48 hours. The TPA that's given, you only have about 4 to 4.5 hours after the stroke symptoms start to give the patient the TPA. So if it's been longer than that since their stroke symptoms started, they're kind of out of luck. So that's why you really need to get that word out, that patients need to come into the hospital quickly. There's some preventative strategies that can be used to help prevent strokes in people who are likely to get them otherwise. One of the strategies is to give antiplatelet drugs to all patients who have risk factors for strokes. Antiplatelet drugs will prevent platelets from sticking to each other and forming clots. And a couple of these drugs are things like Plavix, Ticlid, and even aspirin itself. One of its properties is as an antiplatelet drug or antiplatelet inhibitor. There are also some surgical interventions that can be done to prevent strokes in patients that we think or know have a lot of occlusions. So one of the tests they will do on a lot of patients they suspect of having occlusions is a Doppler or an ultrasound of their carotid arteries, and they will check to see how much occlusion is present. If it's less than 70%, they won't do anything because our body has a pretty good capacity to form collateral circulation around where these blockages are. But if there's 70% or more occlusion, they will usually try to do something. And there's several different surgical procedures. There are pictures of them in your book. But one of them is the carotid endarterectomy, which has been done for many years. And the carotid endarterectomy, I'll show you, there's some pictures here on the next slide of some of the procedures that can be done to prevent strokes by removing the carotid endarterectomy. It opens up the whole entire carotid artery here, and then they go in and actually excise all this plaque, and then they sew the artery back up. So the patient has a pretty big scar, but they're usually able to go home either that same day or the next day. And of course they have gotten rid of the risk of that artery blocking off from the fatty plaque. Then there's a device called a Mercy retriever, and they can send that into the artery. They start at the groin, and they feed a catheter up through the groin and up through the arterial circulation till they get up to the neck. And then what they do is they have this coily thing at the end of the catheter, and they just slowly take this thing in a spiral fashion and suck out the clot. And then down here they're doing a balloon angioplasty, which helps them to help you. There's a couple of things you want to think about when you're dealing with an older person and a stroke. Obviously, stroke is a significant cause of death and disability among older adults. As a nurse, you have the opportunity to assist patients through acute hospitalization, rehab, and long-term care and home care. So keep in mind that it's not just the patient you're dealing with, but the patient's family require ongoing assessment and adaptation to their changing needs. So when you're nursing a stroke patient, you're really nursing the whole family because they're all going to need to make adjustments.